Welcome to another episode of Clear Lake Connections, where we talk to the people behind the businesses of Bay Area Houston. Special guest today with UTMB is Dr. Neil Mehta. And so I read your article in the Journal of Gerontology.
Sure.
Tell us what gerontology is and how you got into that type of study.
Sure, absolutely. So gerontology is the study of aging, essentially, and the study of the elderly. It's a wide field. You have within the field clinicians, physicians. Mm-hmm. You also have PhD trained researchers who study all aspects of aging, from the biology, from the cells, all the way up to social function and social issues related to elderly well-being, so on and so forth. So it's a really big field. And
the gist of the article was that the U.S. is kind of lagging behind in this area. Is that correct?
Sure. Well, the U.S. is lagging behind in overall population health, so just our health, our public health, and also in our life expectancy, which is a really, really important indicator of development. And the issue is important because we wouldn't expect that, right? We have one of the most robust, dynamic economies in the world. And usually a good economy translates into good health. And we have good health overall, but we're lagging behind almost every other high-income country. Now, we've been lagging behind for at least 5 decades. But since about 2010, that lag or that shortfall has gotten even worse. So in 1980, we were sort of middle of the pack in terms of life expectancy. Mm-hmm. And by the time we got to the early 2000s, we were last.
Wow.
And that's very concerning. That's very troubling.
And so there's a lot of factors that go into that.
Absolutely.
Okay.
Absolutely. And the special issue that we published in the Journal of Gerontology tried to look at some of these factors.
And so what are some of those factors?
Sure, absolutely. And it's so the way we sort of think about this is, okay, so life expectancy is a measure of sort of average death rates, mm-hmm. right? And that tells us something, but it doesn't tell us a lot, right? So we want to sort of delve deeper and look into specific causes of death, because once we understand the specific causes, that helps us get at what we call mechanisms of why this is happening. Why are we dying more from, let's say, cancer versus cardiovascular disease, right? There's different risk factors. Second, we look at age groups very, very carefully, right? Because if you don't mind, what kills us at older age is very different than what kills us at younger ages, right? So we started delving, me and others who've been working in this area, we've been starting delving into looking at some of these details to help us get at that question of why, right? Why are we lagging? And not only why, but what can we do about it to improve population health and life expectancy in the U.S.? So the short answer is that we're sort of doing worse on almost every cause of death, unfortunately. So we have much higher death rates from accidents, injuries, and firearms. We also have higher death rates from cardiovascular disease. Cancer, we tend to do, there's a lot of cancers and a lot of risk factors for cancers. Certain cancers we do worse on, especially those related to cigarette smoking and also those related to diet, like colon cancer, right? But otherwise, we're not always, if you look at specific cancers, let's say prostate cancer, for example, we're not doing that badly because we do really well with treating people here. Mm-hmm. Right, so we're sicker for a variety of reasons, but we get excellent medical care. I mean, not all of us, but a lot of us get excellent medical care in this country. So you look at any major sort of cause of death, and we could do a lot better.
Yeah, and I guess a lot of it has to do with, I don't know, I'm originally from Europe. And I've noticed kind of the work-life balance has become an issue,
sure.
and it's becoming more common over here. So maybe that'll, change some of those numbers.
Sure, absolutely. So one of my motivations of going into this area is that, we often think of health just as a product of medical care, right? Getting medicines, going to see your doctor, doing your checkups, so on and so forth. Mm-hmm. But health is determined by so many other factors. And in public health and what we now call population health, we focus on those factors outside of the healthcare system that matter for health. And you may know that UTMB now has a new school of public and population health. Mm-hmm. This is our first week as a full-fledged school with students. We're starting classes this week. And a lot of us in the school focus on what we call these social determinants, these economic determinants, if you will. So one factor that a lot of people are interested in is sort of labor and employment. And, traditionally in the U.S., we work a lot more. Okay? That's not entirely bad. There's a lot of studies that show that working, especially as you get older, is really good for you. It's important for identity. It's important for physical activity, so on and so forth. But work also can cause a lot of stress. And we think stress is connected to a lot of health issues. One factor, probably not the dominant factor that's driving this, is, sort of our work-life balance. We think that, other factors such as our historical smoking levels. So the U.S., last 20 years, on average, we smoke a lot less than people in Europe. But historically, we were the country that smoked the most cigarettes.
Oh, okay.
Right? And that leaves an imprint on our health over 20, 30, 40, 50 years. So we think that's an important factor. Now smoking levels have gone down in the U.S. quite a bit, and they've gone down quite a bit in Europe as well. Going forward, that may not be the driver of why the U.S. is different than Europe. Obesity is turning out to be a big factor, actually, when we look at certain metabolic diseases, when we do a lot of modeling with obesity and mortality. So we think obesity is a major factor. But so is also accidents. We drive a lot more. We have a lot more accidents. We have, much more firearm deaths than almost every other high-income country. These things are playing important roles as well.
So how wide has the gap gotten?
Yeah, why has the gap gotten larger? So in the 1980s, a lot of the lag, the difference, was driven by deaths at younger ages, most prominently accidents, injuries, violence. Okay. Over the last 15 or 20 years, we were still lagging at the older ages, so these are the chronic conditions, but over the last 15 years, we're not doing as well with what's happening at older ages. So since 2010, our death rates from cardiovascular disease mortality or cardiovascular disease has been flat. Okay, and that's a big deal because throughout most of our lives, death rates from cardiovascular disease have declined. They declined to more than 60% between 1960 and 2010. And all of a sudden, that stalled. That improvement continued to varying degrees in other countries, but they completely stopped here. And that's sort of driven up our lag, if you will, or made us, comparatively worse. So a lot of the action, we think, is with what's going on with cardiovascular disease deaths.
And so I'm guessing the last few years with COVID, what do you expect that to do?
Sure. So we already have data on that, right? So we collect data on deaths continuously through vital statistics, and these data are publicly available. Anybody can go look at them and analyze them. And what we found is that we were already lagging in 2019. COVID disproportionately affected us relative to nearly every other high-income country. So we took, I think, about almost a 2-year hit in life expectancy in 2020 because of COVID. Well, while if you look at the average across, let's say, 30 European countries, they took a hit of about 0.7 years or something. So we were disproportionately affected. Now, we can think of COVID as what we would call technically as this period effect. It sort of happens in a year and then we sort of recover, and that's happening, right? So death rates have gone down. We're sort of going back to where we were before. There'll probably still be some signals over the next number of years, and who knows what's going to happen with COVID, but things are looking good. But yeah, so we were already behind in 2019, and then because of this disproportionate effect, we fell even further behind in 2020, 2021, and it's yet to be seen what's going to happen these couple
Yeah, because
years.
you mentioned cardiovascular, and I think people quit going to the doctors, and
Right.
so that's
I
going to
mean,
really...
it was a lot of factors,
Yeah.
right? Like we weren't getting our preventive care. We had just higher levels of infection, throughout most of the country compared to other places. So there was, a lot of factors go into this.
So
Yeah.
healthcare is such a personal thing, right? So
Sure.
What do people need to do on a personal level to kind of, I guess, buck this trend?
Sure. So healthcare is a very personal issue, but we also live in a society that
Yeah.
also and our social experiences our experiences, with our employers. All of these things matter, right? So on a personal level, we sort of know already, right? Like we have preventive measures with diet, with exercise. These are tried and true sort of public health practices, right? That we can all do better at, including myself, right? So that that's really important. But I think also what's important, not just for individuals, but also for employers, for government, is to think about sort of what's called health in all policies. Right, and I'm not just talking about public policies, but how should we think about our communities as being health promoting? Right? How should we think about if I'm an employer, what do I need to provide to my employees to improve their health? And it's more than just their medical insurance, right? It could be this work-life balance.
Yeah.
Right? It could be overall wellness. It could be overall mental health that has impacts on physical health. Right, but thinking about sort of health in all policies, I think would be really, really valuable. In addition to also thinking about good medical insurance and other factors sort of traditionally related to medical care. Right, I think we have to we think that medical care is the most important thing, and maybe these other things are just as important.
Yeah,
I don't want to put numbers on it.
Yeah,
but,
you mentioned mental health, and
Yeah.
for so long people never paid any attention to that, and it's finally becoming, I guess, less taboo to talk about, and people
Sure.
are finally opening up about that. Do you think in those other developed countries that wasn't quite?
It might be similar. I don't know. I think that in some senses, we can lead on these types of issues, right? So we lead in terms of technologies for healthcare. We lead on drug development. I think we've also been a leader in sort of thinking about mental health. We as a society, we as a country. So I don't think mental health was a big thing anywhere prior to a decade ago at most, right?
Yeah.
But that's that's good. That's exciting, and it's important.
So you mentioned you're starting the school. How many
Not me
students?
personally, but we are.
Yeah,
UTMB.
you're a part of it, right?
Sure,
So
yes.
that sounds like an exciting project.
Yeah. So it'll be the fifth school at UTMB. We have 5 departments, I believe. So I'm in the Department of Epidemiology, and we'll have a department on health disparities. We have a department on bioethics, which has been a traditional strength of our school. Department of Global Health, as we're sort of trying to increase our international footprint, and we already have a lot of that activity there. And we have master students coming in. We have a number of doctoral programs, and we just have a lot of support and investment from the university, UTMB, as well as from the UT system.
Yeah.
So it's exciting. It's exciting. It's an exciting time to be faculty there.
Yeah, and how long have you been with UTMB?
2 years.
2 years?
Yeah. So I was previously at the University of Michigan in Ann Arbor, and then I have taught at Emory University.
Okay.
Yeah. So I'm still relatively new here, and it's a really good time, to have joined the faculty.
Yeah.
Yeah.
No, it sounds exciting.
Yeah.
Well, thank you. I appreciate it.
Good. Thank you.